Welcome to this explainer. Today we are unpacking a really profound paradigm shift in how modern neuroscience and psychiatry view ADHD. For a very long time, society's view of attention deficit/hyperactivity disorder was incredibly narrow and, frankly, a bit blurry. But the latest clinical research? It has brought it into sharp, high-definition focus. What was once seen as just a simple behavioral issue is now recognized as a complex, lifespan condition rooted deeply in genetics, environment, and neurobiology. We are going to cover everything today. Literally everything from the shifting symptoms to modern treatment to break down exactly what the data tells us right now.
For decades, when most people heard the term ADHD, they immediately pictured a hyperactive little boy who just couldn't sit still in a classroom. It was widely treated as a childhood phase, right? Something kids simply outgrow once they hit adulthood. But the latest data has completely debunked that outdated stereotype. So, is this condition truly something people just grow out of? Well, the short answer is a resounding no.
All right, let's dive right into this. Here's our roadmap for today. Number 1, redefining ADHD. 2, shifting symptoms across the lifespan. 3, inside the ADHD brain. 4, the comorbidity rule. And 5, modern multimodal treatment.
Section 1. Redefining ADHD, a century of evolution.
So the story actually kicks off all the way back in 1902 when Sir George Frederick Still described children with what he called defects in moral control. I mean, think about how stigmatizing that is today, viewing a neurodevelopmental difference as a literal moral failing. Fast forward to 1937, Charles Bradley inadvertently discovered that benzodrine, which is an amphetamine, actually had a calming therapeutic effect on hyperactive kids. Then in 1968, the DSM-2 introduced hyperkinetic reaction of childhood, heavily emphasizing physical motor restlessness. But it wasn't until 1980, with the DSM-3, that the focus fundamentally shifted toward cognitive attention, which gave us the term ADD, or Attention Deficit Disorder. The evolution here is absolutely staggering. We went all the way from a perceived moral defect to a recognized cognitive attention issue.
When we look at today's modern diagnostic frameworks, like the DSM-5-TR and the ICD-11, both firmly classify ADHD as a neurodevelopmental disorder. But notice the symptom thresholds. For children, the DSM requires 6 or more symptoms, while the ICD relies on clinical significance without a strict number. But here's the real game changer. Look at the adults. The DSM specifically lowers the threshold to 5 or more symptoms. This is a critical distinction because it formally acknowledges that the symptoms persist, they just look different as a patient ages. Now, this evolution in the diagnostic criteria also helps us understand a massive historical blind spot, particularly when it comes to female patients. And that brings us to the concept of masking or camouflaging. This is the conscious or even subconscious exertion of immense cognitive effort to hide executive function deficits. Historically, females were way more likely to present with inattentive traits rather than the disruptive, hyperactive behaviors. Because they weren't causing trouble in class, and because they used this immense cognitive effort to mask their struggles, they were totally missed. Oftentimes, it isn't until adulthood, when the demands of life suddenly skyrocket and those compensatory mechanisms collapse, that they finally get a proper diagnosis. Which brings us to Section 2, shifting symptoms across the lifespan. We call this the phenotypic shift, and it brilliantly paints a picture of what it's like growing up with ADHD. Take hyperactivity, for example. In a child aged 4 to 12, it literally looks like running around constantly, acting as if they're driven by a motor. By adolescence, this turns into extreme fidgeting. But in adulthood, that physical hyperactivity internalizes into a subjective inner restlessness, or overworking, or excessive talking. Same goes for impulsivity. It shifts from darting into streets as a kid to risky driving as a teen to impulsive spending or just quitting jobs out of the blue as an adult. And inattention evolves from losing your homework in childhood to chronic procrastination and totally paralyzing executive dysfunction in adulthood. The disorder doesn't just disappear. It simply changes its clothes. And this perfectly explains why we see such a striking diagnostic ratio shift. In childhood, the male-to-female diagnostic ratio is heavily skewed. We're talking roughly 3 to 1. But in adulthood, that ratio completely equalizes to nearly 1 to 1. This proves that ADHD was never just a boy's disorder. That equalization in adulthood confirms the condition is fluid, and our early diagnostic practices simply failed to catch the less externally disruptive presentations that were being heavily masked.
Let's look under the hood. Section 3. Inside the brain. Neurobiology of ADHD.
Current neuroscientific consensus relies on network theory.
basically looking at how different regions of the brain talk to each other. Let's look at the default mode network, or DMN. This is a task-negative network. It's active when you're resting, daydreaming, or deep in introspection. Think of it like a light switch. In a neurotypical brain, when you need to focus on a complex task, the daydreaming network turns off, and the focus network, the central executive network, turns on. Simple, right? But in the ADHD brain, that switch is faulty. The default mode network fails to deactivate properly. So your daydreaming state is literally competing with your focus state at the exact same time.
But why does this happen? Is it bad parenting? Too much screen time? Nope. Check this out. 0.74. That is the heritability estimate from twin, family, and adoption studies. This makes ADHD one of the most highly heritable psychiatric disorders in existence. We are looking at a profound genetic and biological reality here, and knowing this completely destroys that outdated stigma that ADHD is just a behavioral choice or result of being lazy.
We can physically see this biological reality in the structure and chemistry of the brain. Structural MRI studies actually show delayed cortical maturation. In neurotypical controls, cortical maturation peaks around age 7.5, but in ADHD brains, it doesn't peak until age 10.5, alongside volumetric reductions in areas like the amygdala and hippocampus. Furthermore, there's catecholaminergic dysregulation, which, honestly, is just a fancy way of saying the brain's chemical messengers, like dopamine and norepinephrine, are out of balance. It's kind of like a leaky bucket. Dopamine transporters clear the dopamine away way too rapidly from the synaptic cleft, completely undermining the brain's reward and delay circuits. Oh, and if you needed even more proof of the genetic component, a massive 2023 Genome-Wide Association Study identified 27 specific genetic risk loci associated with the disorder.
Section 4. The comorbidity rule, a harsh clinical reality.
The clinical reality here is stark. Comorbidities in ADHD are the rule, they are not the exception. A purely isolated presentation of ADHD is actually clinically rare. Up to 70 to 80% of individuals with ADHD will meet the criteria for at least one comorbid psychiatric disorder in their lifetime. Compare that to just 20 to 30% who have an isolated presentation. This means clinicians absolutely have to look for co-occurring conditions, rather than just assuming ADHD is existing in a vacuum. And I can't stress this enough, the stakes of untreated ADHD are incredibly high. The research outlines severe functional impairments that span across multiple domains of life. Academically and occupationally, we see high rates of school dropout, lower lifetime earnings, and frequent job turnover. Medically, there's an increased risk for obesity, type 2 diabetes, sleep disorders, and significantly higher rates of accidental injury and mortality. Interpersonally, it often leads to peer rejection in childhood and higher rates of relationship dissolution in adulthood. So this isn't just about struggling to finish a homework assignment. This is a condition with real-world, life-altering medical and academic consequences. So what do we do about it? Section 5. Multimodal treatment. Modern interventions. Knowing the severity of those functional impairments and the hard biological reality of the disorder, how do we actually manage it today? Well, the international clinical consensus mandates a multimodal treatment approach that escalates and adapts based on age. For preschoolers under 6, behavioral parent training is the strict first-line intervention. Then, as children reach school age between 6 and 12, the recommendation shifts to FDA-approved medications combined with that parent training in crucial classroom accommodations like IEPs or 504 plans. Finally, for adolescents and adults, pharmacotherapy becomes the primary intervention for core symptoms, supplemented with specialized cognitive behavioral therapy. The intervention literally has to shift alongside the patient's lifespan. What's really fascinating here is the dual-pronged attack of modern treatment. On one side, you have pharmacotherapy, like amphetamines and methylphenidate, which directly target the core neurobiological symptoms. They are literally addressing that leaky dopamine bucket we discussed earlier. On the other side, psychosocial treatments like specialized CBT and behavioral parent training target the functional outcomes and coping skills. The medication provides the biological capability to focus, sure, but the skills training provides the organizational scaffolding and emotional regulation you actually need to succeed. In fact, one study explicitly proved that skills training provides significant additive benefits over medication alone. So the absolutely crucial point here is understanding what experts call the point of performance deficit. Because ADHD is fundamentally an executive function and working memory issue, general advice or skills learned sitting in a therapist's office often fail to translate to the real world. Behavioral strategies must be applied exactly when and where the executive failure occurs. Immediate situational scaffolding is required at the exact moment a task needs to be executed, which is exactly why structural accommodations in classrooms and workplaces are so incredibly vital.
Well, we've covered a lot today, everything from the history and the biology to the shifting symptoms and modern treatments of ADHD. It is crystal clear that this is a complex, biological, lifespan condition, not a behavioral choice. So I want to leave you with a final thought to reflect on. How would our workplaces, our schools, and our society as a whole change if we actually accommodated these point-of-performance neurodivergent deficits rather than punishing them? The data shows us exactly what ADHD is. Now it's up to us to build an environment that supports it. Thanks so much for joining me on this explainer.